Today we'll be discussing about stylalgia or eagle syndrome. What is stylalgia? Algia means pain in some part of the body. Stylalgia is pain produced due to problems with the styloid process. It is a pain in the facial region that is caused due to an elongation of the styloid process or a calcification or mineralization of the stylohyoid ligament. Coming to anatomy, what is styloid process? Styloid process is a slender, elongated, cylindrical process that projects from the inferior part of the petrous part of the temporal bone, and the tip of it lies between the internal and the external carotid arteries. It lies andromedial to the stylomastoid foramen and is also related to the internal jugular vein. The superior constrictor muscle and the pharyngobasilar fascia are related to the tip of the styloid process medially adjacent to the tonsillar fossa. The normal length of the styloid process is 2 to 3 centimeter. 2.5 to 3 centimeter. That anything more than 3 is considered as an elongated styloid process. Usually the styloid process is straight as seen in the picture, but sometimes it can be curved or angulated. The curve or angulation of the styloid process is also related to the development of symptoms of an elongated styloid process. Whenever you think about a bone, you should think about the muscle attachments. So what are the attachments of the styloid process? There are 3 muscles and 2 ligaments attached to the styloid process. So styloid process is here. So think about the region here. So there are muscles that is attached to the tongue, that is styloglossus. Then the pharynx is nearby, the stylopharyngeus. Then you have the hyoid bone here, so stylohyoid. So 3 muscles, styloglossus, stylopharyngeus, stylohyoid. Styloglossus, because it is attached to the tongue, it is supplied by the hypoglossal nerve. Stylopharyngeus is supplied by the glossopharyngeal nerve. It is attached to the thyroid cartilage. It is a pharyngeal muscle, so supplied by the glossopharyngeal nerve. And stylohyoid, as you know, is supplied by the facial nerve. So the 3 muscles are supplied by 3 different nerves. Then there are 2 ligaments, stylohyoid ligament. The stylohyoid ligament attaches to the lesser corner of the hyoid bone, and the stylomandibular ligament. Calcification or ossification of these ligaments can also give symptoms of an elongated styloid process. And so this muscles, ligaments, the styloid process and the lesser corner of hyoid bone together is known as the stylohyoid complex. The styloid process plays an important role in dividing the parapharyngeal space. Anatomy of parapharyngeal space is for another video, but I'll just remind you what are the structures in the parapharyngeal space so that you can remember the relation of the styloid process. So the styloid process divides the parapharyngeal space into prestyloid and retrostyloid compartments. Prestyloid is androlateral. It contains fat and the retromandibular parotid gland. The retrostyloid compartment is posteromedial. It contains the internal carotid artery, internal jugular vein, cranial nerves, 9 to 11, some lymph node, and also the sympathetic plexus. What happens when the styloid process is elongated or the stylohyoid ligament is ossified and calcified? It will irritate on all the structures that is surrounding the styloid process. Coming to what is the pathology that causes this elongation of the styloid process or ossification of stylohyoid ligament? For that, you have to remember the embryology. We have different pharyngeal arches. The arch in this context is second pharyngeal arch. You know that yes, styloid process, stylohyoid ligament. The smaller cone of the hyoid, that is lesser cone of the hyoid, develops from the second pharyngeal arch. Yes, for us. And the second pharyngeal arch cartilage is the Richards cartilage. So the Richards cartilage has 4 different segments. If you think that this is little too much for you, you can skip this part. But the Richards cartilage has 4 different segments. So the tympanohyal segment, the stylohyal segment, ceratohyal segment, and hypohyal segment. You just remember that the tympanohyal segment is present antenatally, that is before birth itself, and that part gives rise to the tympanic segment and also the stapes part and also the most proximal part of the styloid process that is embedded in the tympanic part. The stylohyal segment develops postnatally, and that gives rise to the remaining part of the styloid process and the stylohyoid ligament. So these two develop separately, and in some people they fuse together, some people they do not fuse, and the difference in the ossification and fusion of the stylohyal and the tympanohyal segments give rise to different lengths of the styloid process. The stylohyal part gives rise to the proximal part of the stylohyoid ligament. So the distal part is formed by the serrative hyoid segments. The styloid process starts ossification immediately after birth, at the end of pregnancy and immediately after birth, and then this ossification continues till 8 years of age. Anything that affects this will cause an elongated styloid process. And also there's another theory that any pharyngeal trauma, any chronic inflammation, any fracture of the styloid process, any other autoimmune inflammatory diseases that affects the head and neck area, it causes chronic inflammation, and as a reaction to the inflammation, the styloid process will undergo calcification, or the stylohyoid ligaments can undergo calcification and elongate. And according to Steinman, there are 4 theories that causes difference in the ossification and elongation of styloid process. First one is I explained any pharyngeal trauma causing reactive ossification of the styloid process. That is known as theory of reactive hyperplasia. Second one is reactive metaplasia. Metaplasia is something that is not there is coming there. That is a stylohyoid ligament. Usually is not bony. So stylohyoid ligament is ossifying. That is reactive metaplasia. Third one is anatomic variance. It is explained that the length and difference in the length is a variation of a normal anatomy. Fourth is from the Richard's cartilage, if there is any embryonic cell rest, that will promote the ossification of the styloid process. There are 2 types of stylalgia. First one is a classical stylalgia, that is due to the elongated styloid process irritating the surrounding structures and nerves. Then there is another condition also known as stylocarotid syndrome, that is due to compression on the internal carotid artery or the external carotid artery, and also the compression of the sympathetic plexus. I'll explain the symptoms of stylocarotid syndrome in the symptoms in the presenting complaint. Another interesting thing that you have to know is in the general population, incidence of an elongated styloid process is around 4%. But among the 4% of people who have an elongated styloid process, only 4% will have symptoms. Even though the elongated styloid process can occur bilaterally, but patient will have symptom only on one side. And the usual classical stylalgia can be precipitated after a pharyngeal surgery or tonsillectomy, etc., due to fibrosis. So even though there is an elongated styloid process for 4% of population, only 4% will have symptoms. Even though the styloid process elongated bilaterally, patients usually have unilateral symptoms. What are the presenting complaints? It is more common in females than in males. Mostly the patient would have gone to multiple places for cervicofacial pain and would have taken multiple treatments before the patient comes to you. So you always have to keep a level of suspicion when patient is complaining of pain around the face. Usually patient will complain about pain in the throat, tonsillar area, in the pharynx. There will be sharp pain in the neck or the ear that can radiate into the cheek, into the temporomandibular joint, into the oral cavity, into the neck, shoulders. So pain is the main thing. Patient can also have foreign body sensation in the throat, difficulty in swallowing or pain while swallowing. Then patient can have ear pain, that is referred otalgia, abnormal sound in the ear, tinnitus, and also giddiness. Patient can also complain of increased salivation. That can also be associated trismus, that is inability to open the jaw, and also change in voice. The patient can hit multiple attacks or bouts or attacks of pain, which can be triggered by many things, just by turning the head, laughing, coughing, chewing. All this can trigger the pain attack, which can be radiating to the entire area of the space. Usually the patient will complain on unilateral side. In stylocarotid syndrome, the styloid process is impinging on the internal carotid artery, external carotid artery, and also on the pharyngeal plexus. So the patient will have pharyngeal pain, eye pain, headache. It can resemble a migraine or a cluster headache. And also if there is compression of the internal carotid artery, which is severe compression, patient can have symptoms of deficiency of the internal carotid artery blood supply, that is weakness, giddiness, visual changes, syncope, which can be exacerbated by head movements. What are the clinical examination findings? You have to keep the diagnosis of stylalgia in your differential diagnosis when a patient comes with cervicofacial pain, radiating pain, and you have to palpate the tonsillar fossa and see. Usually the styloid process is not palpated, cannot be palpated in the tonsillar fossa. And if the styloid process can be palpated in the tonsillar fossa, it means it is elongated. And also, while you are palpating the styloid process, patient will have this attack of pain or symptoms. What are the differential diagnoses that you have to think about? You have to think about TMJ arthralgia, trigeminal neuralgia, any pharyngeal infection, any inflammatory or any malignant lesions of pharynx, base of tongue, lateral border of tongue, any oral cavity lesions. All this you have to rule out. You have to rule out any dental infections, especially if the third molar infections. and also inflammatory conditions, so that is osteoarthritis of the cervical vertebrae, rheumatoid arthritis of the hyoid bone, etc. You have to rule out, and also chronic stress and migraine can also cause similar symptoms. So just keep an index of suspicion of stylohyoid syndrome or stylalgia when patient comes with cervicofacial pain, and then you can go in for the investigation. You can do a radiographic investigation, that is take an X-ray of the skull, AP and lateral view. So that sounds view, AP view is sounds view. We can see that the styloid process is elongated. A plain X-ray is sufficient to diagnose an elongated styloid process. Also, you can take an OPG, orthopantomogram, to compare the sites if required, to see if any dental issues or any bone issues are there. The gold standard of imaging that now we use is CT. A 3D reconstruction of CT can help you to identify the length of the styloid process, and also in CT you can identify the angulation and whether the structures are compressed. Everything you can assess in the CT. If you're suspecting a stylocarotid syndrome, and if you're suspecting there is impingement of the blood flow of the internal carotid artery, you can do a CT angio also, that will help you to assess the blood flow. The elongated styloid process can be classified by Correll into 3 types. Type 1, uninterrupted elongated styloid process. Type 2 is the styloid process joined to the stylohyoid ligament by a single articulation. You can see a single black thing at the joint in CT when you are seeing. Type 3 is interrupted segment of the mineralized ligament. You will be able to see different pseudo articulations. So those are the 3 types. So another test that you can do is a lidocaine infiltration test. You infiltrate 1 ml of 2% lidocaine in the area around where you are palpating the styloid process and tonsil process. Around that you can infiltrate the lidocaine, and the patient will say that there is a relief of symptoms. What is the treatment for stylalgia? Medical treatment, you can give your normal analgesics. You can start with the paracetamol, and NSAIDs you can give. If the patient is not sleeping at night due to anticipation of, you can also give tramadol. Because it is a neural pain, you can give your antipsychotics and anticonvulsant drugs like gabapentin, amitriptyline are found to be effective for treating this kind of patients. You can also give an oral dose of short course of steroids, and also a single injection of steroid and a local anesthetic at that styloid process area. Can usually give triamcinolone and bupivacaine injection. 1 ml of triamcinolone, that is 10 mg, plus 3 ml mepivacaine, that is 3 mg mepivacaine, can be injected into the tonsillar fossa as a single dose injection. The pathology is this styloid process irritating the surrounding structures, and there is some kind of inflammation. So these anti-inflammatory drugs and NSAIDs will reduce the inflammation, and also it will alter the pain pathway. And because it's a neural pain, when you give your gabapentin or amitriptyline, the neurotransmitter release is regulated and the pain can be controlled. The patient usually shows response within the first 10 or 15 days. Patient will say that I am finding improvement in the pain. You have to continue the medical treatment for 3 to 6 months at least. If the patient is not improving with the medical treatment, we can go for surgical treatment, that is excision of the elongated styloid process. That is styloidectomy. The styloidectomy can be done as a partial styloidectomy or complete styloidectomy. I do partial styloidectomy. It can be done via an intraoral approach or through an transcervical extraoral approach. In my institution, we usually do transoral approach. We are ENT surgeons, so we are so used to going through the mouth. So I usually prefer a transoral, transtonsillar approach to the styloid process. It is actually a very minimally invasive procedure. So under GA, the patient is in the tonsillectomy position. That is your Ross's question. Mouth gag, everything is inserted. And initially you do a tonsillectomy in your dissection and snare method. And then you identify the styloid process, delineate it, and just the tip of the styloid process can be excised. There is any gap in the superior constructor, you can suture it. So in this way, what happens is we are using only a minimal small incision, and we are using the superior constructor muscle, the tonsillar bed's constructor action, to prevent any infection from going inside, reduce bleeding and increased healing. The only thing is we will not be able to delineate and find out all the parapharyngeal space components and all that. So it is a shorter operating time, faster recovery, faster healing, etc. Everything is better with the transoral approach. Extraoral approach or transcervical approach is you can see the entire structures and then remove the styloid process. But the thing is you will have a big scar, that is a scar from the mastoid process to the hyoid. And also there is chances of the marginal mandibular nerve injury during a cervical approach. Styloidectomy can be performed in patients who are not responding to medical treatment. What are the complications? The complications of surgery, as usual, hemorrhage infections, deep neck space infections, etc. And also 20% of people post-surgery also the pain can persist due to the involvement of the glossopharyngeal nerve due to post-operative fibrosis and all this. For that, you have to give medical treatment only. Stylalgia, Eagle syndrome, elongated styloid process of stylohyoid ligament. It can also be caused due to calcification of the posterior belly of digastric or the stylohyoid muscle and patient presents with cervicofacial pain. You should always have a high index of suspicion. And radiograph will give you the image of the elongated styloid process, and CT will give you the length and angulation of the styloid process. Give medical treatment. If not improving, go for styloidectomy.